Hi, my name is Alicia Novak. Today I will be discussing the Trans-Theoretical Model of Change, also known as TTM, or the Stages of Change model. The Trans-Theoretical Model of Change was developed and introduced by James O. Prochaska and Carlo C. Di Clemente. Prochaska and Di Clemente utilized multiple concepts of change from over 300 theories of psychotherapy in order to define and describe the stages and processes of change. Some theories which have lent concepts to the TTM include the health behavior model, the theory of reasoned action, and the social learning theory. The TTM then transformed into a model of intentional change and focused primarily on the decision-making of the individual. Previously, the leading theories tended to focus on social influences or biological influences on behavior. The theory of change was originally developed in 1977, redefined in 1983, and introduced in Prochaska and Di Clemente's study entitled Stages and Processes of Self-Change of Smoking toward an Integrative Model of Change. Prochaska and Di Clemente utilized a longitudinal design to examine why some individuals were able to quit smoking independently and others were unable to do so. They followed the participants for 2 years and utilized questionnaires and saliva samples to monitor the participants' smoking statuses. They also monitored how often the participants utilized the processes of change. At the conclusion of the study, a relationship between an individual's readiness to quit smoking and their subsequent ability to quit smoking was identified. In addition, the study showed how the stages of change were successfully or unsuccessfully transitioned through. The TTM is a middle-range theory. Therefore, it has a narrow focus and focuses more on specific phenomenon in regards to patient care, as opposed to focusing on nursing as a whole. Because it is a middle-range theory, the concepts are more concrete and there is a lower level of abstraction. Therefore, the TTM is better able to be tested empirically and utilized as an evidence-based theory. The TTM specifically focuses on behavior changes and is therefore most efficacious when applied to patient education. The TTM is based on an individual's ability to implement an intentional change in their behavior as a result of their readiness and willingness to change. It defines steps to guide individuals through a behavior change in order to facilitate successful and lasting behavior change. And it helps to explain why some people are able to successfully change their behavior while others are unsuccessful. The concepts of the TTM include the stages of change, the process of change, decisional balance, self-efficacy, and temptation. The stages of change include the pre-contemplation stage, in which the individual has no intention of change and is not ready to change their behavior now or in the near future. At this stage, a decisional balance of weighing pros and cons can be implemented to instruct the individual in the benefit of changing from an unhealthy behavior to a healthier behavior. The contemplation stage is when an individual is beginning to consider a change. They are aware of the problem and of the desired behavior change. Further evaluation and teaching in regards to pros and cons can be utilized at this stage. The preparation stage is when they are ready for change and just beginning to take action to change the behavior. Individuals require encouragement and continued evaluation and explanation of pros and cons at this time. The action stage is when an individual is making lifestyle modifications and actively changing their behavior. During this stage, the individual requires acquisition of self-efficacy and the ability to take steps in order to avoid temptation and relapse. The maintenance stage is the stage in which continuous efforts are ongoing to maintain the positive behavior change and avoid relapse. Individuals tend to be more self-efficacious and less likely to relapse during this stage. Subsequently, a sixth stage of change was introduced. This stage is known as the termination stage. During the termination stage, the behavioral change is permanent and the individual no longer has any temptation to relapse. The process of change is how an individual moves through the stages of change. There are 5 experiential processes and 5 behavioral processes. The experiential process of consciousness raising involves developing one's own awareness about the problem. Dramatic relief occurs when emotions about the problem and treatment are invoked. Environmental reevaluation is when the impact of the behavior on one's environment is evaluated. Self-reevaluation occurs when an individual is looking inward to evaluate their thoughts and emotions in regard to the problem behavior. And social liberation involves decreasing the problem behavior within the social context. The behavioral process of reinforcement management rewards positive behavioral changes. Helping relationships occur when the individual is able to talk openly about the problem to a support person. Counterconditioning occurs when problem behaviors are replaced by positive behaviors. Stimulus control involves controlling temptations that may lead to relapse. And self-liberation involves committing to and maintaining a behavior change. In order to begin making a change in one's behavior, a decisional balance must be made. A decisional balance, which was adopted from Janis and Mann's work in 1977, is when an individual weighs the pros and cons of changing and makes a decision whether or not to change a behavior. After a decision to change a behavior is made, an individual will work their way through the stages of change by means of the process of change. During the final stages of change, the individual will need self-efficacy to avoid temptation and relapse. Temptation is the urge to relapse in a difficult situation, such as emotional stress, cravings, and varying social situations. Self-efficacy, based on Bandura's construct of 1997, is how confident one is in dealing with risky situations without relapsing. Self-efficacy has been shown to increase as individuals transition from pre-contemplation to maintenance. The stages, processes, and concepts of the TTM operate in an integrative loop. An individual will work through the stages of change utilizing the processes of change. However, when a relapse does occur, the individual will likely re-enter the contemplation stage and resume the process from that point. In order to achieve maintenance, the individual will need to develop self-efficacy in order to avoid relapse. The TTM is a very advantageous theory in regards to nursing practice. One of the biggest goals or obstacles we face as nurses is how to get a patient to want to change their unhealthy behavior, to proceed through the stages of change, and then to maintain this change. Non-compliance with diet, weight loss, exercise treatment, etc., is a huge obstacle to overcome in order to help our patients achieve and maintain optimal health. In addition, this model can address patterns of addiction and provide a basis for working through the cycle of remission, temptation, and relapse. This theory can also be utilized to understand where a patient is within the stages of change in order to assist them to change from an unhealthy behavior to a healthier behavior. Therefore, specific areas in which this theory may be helpful include smoking cessation, exercise, diet modification, alcohol abuse, drug abuse, health prevention measures, and medical compliance. There are also many tools that utilize the TTM. For instance, the Rhode Island Change Assessment Scale is a 32-item questionnaire designed to measure an individual's readiness to change when they begin addiction treatment. In addition, motivational enhancement therapy is a counseling approach that helps individuals to identify pros of drug cessation and become more engaged in the treatment process. Within the primary care setting, we can utilize the Readiness to Change ruler and the agenda setting chart. The Readiness to Change ruler uses a straight line to represent a continuum from the left, which is not prepared to change, to the right, which is ready to change. Patients can identify where they are in the stages of change, and providers can then elicit motivational statements in regards to readiness to change and perceived barriers. The agenda setting chart is used with chronic disease management when multiple lifestyle changes are necessary. The provider can draw circles on a paper and fill in the circles with behavior changes that are efficacious in disease management. In addition, a few circles will be left blank. The patient then has the opportunity to add their own ideas to the blank circles in regards to what behavior changes they identify as being helpful to maintain optimal health. The utilization of these tools in nursing can provide an efficacious and cost-effective way in which to identify patients who are ready to change their behavior, ways to motivate a patient to change their behavior, and potential barriers in initiating or maintaining a change in that behavior. The question then becomes, does the research support the use of TTM? A meta-analysis by Marshall and Bidell examined the effectiveness of the TTM on exercise and physical activity. They noted that the application of the TTM is justified as the results identified core constructs that differed across the varying stages and revealed that most changes noted were in direct alliance with those predicted by this theory. However, they did find it difficult to identify the higher order constructs of the process of change related to physical activity. They suggest that further research should focus on examination of the mediators of stage transition. The TTM offers a considerable amount of generalizability. However, there's rarely a one-size-fits-all approach that can be applied to all populations or across all social and cultural spectrums. Individuals may at times advance or regress through the stages in ways that the TTM cannot explain. For example, Mackney and McCabe performed a cross-sectional study to identify the applicability of the TTM to Southern Appalachian smokers. The results revealed a significant variation across the first three stages when compared to the national samples. Therefore, the TTM may not be able to be generalized to all social and cultural populations. However, overall, the TTM has been shown to be a useful theory to utilize within nursing and research. Prochaska, Wright, and Valissier applied the hierarchy of criteria to the TTM to evaluate the credibility of this theory. They found that the TTM met all of the following criteria. Therefore, the TTM is able to be utilized in practice and research in its current form without adjustments needed at this time. There are also currently many studies which have proven the efficacy of the TTM. For instance, Guhuramani, Musavai, Kaveh, and Gam performed a quasi-experimental study and recruited 168 Iranian women. In the interventional group, they implemented self-care education based on the TTM related to the benefits of self-breast examination. The results confirm the effectiveness of educational interventions based on the TTM on increasing the participants' utilization of breast self-examination when compared to the control group. In addition, Emdadi, Nilsaz, Hosseini, and Sarabi conducted a cross-sectional descriptive study in order to study the exercise behavior among female college students with application of the TTM. The results showed that the constructs differed significantly across the exercise stages in conjunction with the stages of the TTM. Therefore, they support the use of the TTM in regards to examining exercise behaviors. Lastly, Mistelos, Gunn, Felix, Carr, and Mahid performed a systematic review of randomized control trials. They included just under 3,000 participants in order to determine the effectiveness of dietary and physical activity interventions based on the TTM on sustainable 1 year or longer weight loss in overweight or obese adults. The results showed that application of the TTM led to improvements in physical activity, exercise, and dietary habits. In conclusion, based on the evidence, I believe that the TTM is beneficial to nursing and should be utilized in practice, education, and research. The ability of the theory to be tested empirically improves the overall credibility of this theory and makes it fit well with current nursing standards. The most important areas of nursing that can be improved upon with the use of the TTM are education, behavior modification, and addiction. These areas are very important to patients' health and well-being. Implementing the TTM theory is a cost-effective way to assist our patients in these areas and to improve their overall health.